The area being assessed here is the hip, and the safe setup for this movement is to ensure that the patient is lying both on their back as well as on their front whilst going through active, passive and resisted range of movement. And the practitioner needs to ensure that they are clearly communicating what they are about to do so that the client understands the movement that they are going to perform. And also make sure that the bed is at a good height so that the practitioner isn't bending over as it causes pain to the back. And also continue to ask and check on whether the patient is feeling good and comfortable throughout. You must always start off with the uninjured leg when checking the movements. The movement of the hip, there is flexion, extension, which is in the sagittal plane, adduction and abduction, which is in the frontal plane, and in the transverse plane allows for internal and external rotation. Active hip extension. The patient needs to be lying on their front, and the practitioner needs to give a saying such as lift your leg up towards the ceiling. Passive hip extension. To begin with, relax the patient and take control of the leg and place one hand on the back of the pelvis whilst the other hand is on the knee and lift the leg up towards the ceiling. Resisted hip extension. The patient needs to be lying on the front and place one hand on the top of the pelvis and the other hand on the hamstrings. Then the client needs to push the leg up towards the ceiling whilst the practitioner is resisting and pushing against in the opposite direction. Active flexion. The patient should be lying on their back and needs to bring the knee up towards the chest and bend the hip. Passive flexion. For this movement, you need to ensure that you are taking the full weight of the leg whilst making sure that the patient isn't tensing. Once you've taken the weight of the body and your hands are placed under the gastrocnemius and above the knee, you bring the leg again up towards the body. Whilst going through his range of motion, the practitioner needs to ensure they are checking the facial reaction of the client to see whether they are showing any symptoms of pain or discomfort, which could include wincing. Resisted flexion. Practitioner places one hand on the distal part of the thigh, and the client needs to bring the leg up towards themselves, whilst the practitioner is resisting them downwards by placing the hands above the knee. Active adduction. Move patients to the edge of the couch and with one leg dangle it on the side of the couch, and with the other leg move it out towards me and towards the other direction of the bed from the neutral position. Passive adduction. Hook one leg off the couch, and with the other leg the practitioner is bringing the leg inwards towards the midline. The practitioner is holding the heel of the client with one hand and the pelvis with the other. Resisted adduction. The practitioner needs to start off by hooking the non-used leg of the couch and place one hand on the side of the foot, trying to push the foot in the opposite direction. For this instance, the client is trying to move the foot inwards towards the other leg, and the practitioner is applying resistance against this. When doing this movement, the practitioner needs to remember to hold the pelvis throughout. Active abduction. The client moves the leg away from the body. Passive abduction. Practitioner takes the weight of the leg with one hand placed beneath the calf and then the other hand placed on the pelvis and bring the leg out away from the body. Resisted abduction. This movement, the practitioner places one hand on the outside of the foot and the other hand on the pelvis and trying to resist the client from moving the leg outwards and away from the body. Internal rotation. The patient needs to bring the leg into hip flexion so it is a 90-degree angle and bring the leg outwards away from the body. Passive internal rotation. To begin with, the practitioner needs to take full control and weight of the leg and take the leg into hip flexion by wrapping one arm around the calf. For this type of rotation, once the leg is in hip flexion, the leg needs to be moved outwards and the other hand needs to be placed on top of the knee. Resisted internal rotation. To begin with, the client needs to resist throughout the whole range of movement. So to start with, the leg will need to be placed into passive external rotation, and once in this position, the patient will try and move the leg outwards, whilst the practitioner is applying pressure to the leg inwards and in the opposite direction. External rotation. Start off with, we need to bring the patient into hip flexion and bring the leg inwards towards your body. Passive external rotation. Take the weight of the leg and bring it into hip flexion by placing one hand around the gastrocnemius and the other arm on the knee. Once the leg is in a 90-degree angle, the leg needs to be moved inwards towards the other leg. Resisted external rotation. The practitioner brings the client to start off with into the passive internal rotation, and the client needs to resist throughout the range whilst the practitioner is trying to push the leg outwards the client needs to resist and push inwards. Once all the movements have been done on a non-injured leg and hip, the practitioner then does movement on the injured hip and the other leg and compare the results. Muscles that are being examined are, for example, the adductor magnus, adductor longus, adductor brevis, piriformis, as well as the ellipsoas, and the functional test for this is the squat.